You're listening to Healthcare Now Radio. Stand by for This Just In, the latest in healthcare innovation and technology trends with your HIT advisor, Justin Barnes.
Thank you for tuning in and welcome to This Just In. I'm your host, Justin Barnes. In these half-hour segments, I'll bring the latest advancements in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as the Healthcare Now radio network. For this episode, my 158th episode, with a very special guest, Dr. Brian Jack from the Boston Medical Center and Boston University School of Medicine. Welcome to the show, my friend.
Thank you, Justin. It's great to be with you.
Yeah, we met, I think the first time was last summer at our very first think tank, and you helped lead the virtual care session speaking about your very cool innovations. And I don't want to get too far ahead of us, so I'll let you announce them on air. But I'm just very excited to have you back on air. I love your passion, your energy, your expertise. You're always on the leading edge of consumer-centric innovation. So we can't wait to dive in and hear more about what you're working on.
Yeah, I appreciate that, Justin. It's really great to be here and to tell your listeners about some of the products that we're very, very interested and very excited about.
Now, so very cool. Before we dive in too deep into the innovation side, tell us a little bit about your background. Where'd you grow up, go to school, medical school, all that good stuff?
Okay. So I'm from Massachusetts and went to the University of Massachusetts Medical School. I then went to Brown University to their family medicine residency program, where I spent 3 years. Then I worked in the emergency room for a year while my wife was finishing her schooling. Then I went to the University of Washington in Washington State to do a fellowship there. Then I came back to join the Brown faculty, where I was for 12 years. And then in 1997, I came to Boston University School of Medicine, where I became the vice chair for the Department of Family Medicine. Later became the chair, and now I am the director of the Center for Health Systems Design and Implementation at Boston University. So I've had a varied career.
Yeah.
I've seen patients, Justin, all the way through my career. And still do. And I think that my patient care has really informed a lot of my research work. So I think that's an important thing.
Yeah, and I knew you're from Massachusetts. I guess I didn't originally know you're from there. So because I'm originally from Amherst, Mass, and I went to school at the University of Massachusetts at Amherst. And then also my sister went to Brown. So we have a lot in common.
There you go. That sounds great.
And I have a very strong affinity for Massachusetts. My wife and I, we go back somewhat frequently. Most of my family is there. I'm one of the only people out of my family that moved south. But we went up back in May and just had an amazing time and focused most of the trip. We stayed only in Boston and focused most of the trip on finding the very best lobster rolls and documenting my lobster roll hunt.
Yeah. That sounds great. Yeah, I think Massachusetts these days, in terms of innovation, is a really terrific place to be. In that the insurance status of Massachusetts back when actually Romney, we all remember him.
Sure, of course.
And, when Romney was governor of Massachusetts before he ran for president.
Yeah.
Really started the early stages of Obamacare. Even though he didn't say it wasn't Obamacare. Really.
Right.
So in those days, there were 78% of people were insured in Massachusetts. Now it's 99%. And that the health status of the people in Massachusetts has really improved drastically as people have become insured and they have access to good, high quality people. But also there is in Massachusetts the Medicaid ACO, of which Boston Medical Center, which is the old Boston City Hospital, is very much involved with, so that the capitation of the Medicaid patients has really incentivized us at Boston Medical Center to really have the incentives necessary to implement new innovations so that we can improve the quality of care and decrease the cost of care. So it's really, the time has come for us to do the things that we've been talking about for a long time.
Yeah, I completely agree. And you actually bring me back to the day. So I work with both sides of the aisle, and I have for my entire career. But I actually advise the Romney campaign when they're running for president, his first run. And I remember going up to Boston, Commercial Street. I think it was 500 Commercial Street was his office, but right on the water there. And had it was actually a great team. Lanhee Chen was one of his right-hand people, and Lonnie now works for the Heritage Foundation, but he makes the news channels almost every week. But he pulled together a great team, but he knew what he was doing for sure in the healthcare side. And obviously I worked a lot with the Obama administration as well, during the whole creation of the health IT, a lot of the health IT components of the ACA. But yeah, it was kind of, you bring me back to the Romney days, which was kind of cool.
Yeah. Yeah, and a lot of the focus now is on the high cost, high utilizing patients in the Medicaid system.
Yep.
And the Medicaid system is now about a third of the entire Massachusetts budget. So there's a real need to decrease costs, and by doing that, by improving care, is the secret. So the top 1% of people in Massachusetts is about 20%, 5% is about 50%.
Wow.
So if we can design new innovations, and I think health information technology is a big piece of that. To care for these high utilizing, high cost patients, then that's really what the next 20 years is about, I think.
I completely agree. It's excellent. So how did you become engaged with health IT and such a pioneer?
Yeah, so I started again through my clinical practice, and when I was in my family practice, I would see patients who had been discharged from the hospital, but I didn't have all the information about what happened in the hospital. And excuse me, and sometimes they would end up back in the hospital because I didn't have the right information about what happened to them. And also when I was in the hospital caring for patients, working on the resident teams, supervising the residents, you could point out like this person and that person, they're going to be right back because we're just not doing the things necessary to ensure their success once they're discharged. So some years ago, I put together a program called the Re-Engineered Discharge Program, Project RED, which is 11 mutually reinforcing components to really define what a high-quality discharge is all about. And that, the discharge before that had not really been studied at all. And the discharge program was marked by poor quality information and communication problems, poor preparation, lots of loose ends, fragmentation. And when we asked patients when they went home from the hospital, what are you most worried about? They would say, we're all by ourselves. That when we call, people don't call us back. We call, we give appointment in 6 weeks. And that's just not good enough. And when people are leaving the hospital, they're not on the top of their cognitive game, that they've been sick, fever, and medicines, and sleeplessness, et cetera. And then we go in and throw a bunch of papers in Latin at them and expect them to understand, what it takes us years and years of schooling to understand the names of the medicines, the 2 names of the medicines, the diagnoses, et cetera. So we designed the Re-Engineered Discharge Program and then did a randomized control trial showing that if we implement these 11 mutually exclusive reinforcing components of what high quality discharge ought to be, that it will reduce readmissions. And we showed a 20% reduction in readmission. So that was something that was really an important thing at that time, which was really before reducing readmissions was as big a deal as it is now. Right. So around that time, they asked me to go over to MIT to the Media Lab and to present a clinical problem, a big clinical problem. And at the same time, they had their graduating PhD students presenting their new technologies that they had developed. And at that time, the Media Lab said that we don't want to develop things that are applicable today, but applicable in 7 years from now. So that timeline is just about right, actually. So Tim Bickmore was a graduating PhD student who had invented really unique new software, which is the animated computerized characters that speak with empathy, and sentences are created in real time from the database behind them. It really is unique software. So I presented readmissions as a big, important problem. Tim presented his new technologies, and then there was a reception afterwards. I said, Tim, do you think we can program one of the characters to help people to better understand what to do for themselves when they go home from the hospital? And he says, I think so. So we wrote a grant, and then we're kind of off and running at that point.
Yeah, and this is what your story here has kind of jolted a lot in me when I first heard it at the think tank last June, because I had just come off an outpatient procedure, and I remember the doctor telling me, hey, everything is fantastic, you're great, I'll see you again in 10 years. And I was so groggy, and I asked him some questions. I actually had some follow-up questions already ready to go, but I was so groggy, I was, sedated. He did give me some input back. I don't remember a single thing from that moment. He could have given me instructions. I have no clue. And so then literally 1 month later, I heard your talk at the think tank, and I'm like, oh my gosh, this, your innovation, Louise, would have helped me so much, with my specific procedure. In your mind, the millions of patients out there.
Yeah, and just think if you're 76 years old and
exactly,
have the cognitive abilities that you have, et cetera. So wouldn't it be great, though, that if you could go home and then log on to Louise and hear those instructions again, and be sure that Louise explains things carefully, which she does, and does teach back to be sure that you do understand, and prints a report out at the end about what you understand and what you don't understand, so that nurses can come in and give you a call and get you back on track.
Yeah. So
when we call people 2 days after discharge, with half of them are doing something wrong with their medications.
Exactly.
And we can do a whole lot better. And I think health information technology will allow us to do that.
So I jumped a little bit ahead, but so tell us about Louise. I mean, I was just very awestruck by seeing the demonstration. I can imagine what the results are, but give us a minute or so on what Louise is specifically.
Yeah, sure. So these are embodied conversational agents, Louise, and the systems are programmed to emulate face-to-face communication. And communication, not just in the words that you speak, but the eyebrows go up, and there's smiles, and there's frowns, and there's empathy actually expressed in the conversation. That the agents confirm understanding through teachback. That when we teach the medications, they'll say, okay, tell me about how many times a day you take care, whatever it is. And it goes along with a little package they have in front of them, the after-hospital care plan. So it's an open book test. They can be looking at the information. Louise explains where the information is and gives a test afterwards after she explains it. But mostly it's tailored information. It's very, very important to understand. It's not information that is just the routine things that people could read. They want to know about what's important to them. So it's their medications, their appointments, their pending tests, et cetera, that Louise reviews with them and is sure that they understand. At the end, there's a report that's printed about what they understand and what they don't understand. Mm-hmm. The average interaction is about 20 to 25 minutes, and people rate it very, very highly.
Yeah, and just for my listeners, because I've had the reason to see this, and so basically it's a screen. They'll sit in front of a screen. It can be a monitor, it could be a phone screen, a computer screen, and it's literally like an animated person. So Louise is a person. So I know I initially just said Louise, and probably most of my listeners did not understand what I was talking about when I said she is a virtual image or an image.
So on some sort of a screen, and so we often will wheel it in on a computer on wheels type of thing, and Louise will say, "Hi, Joe, how are you doing today? I hear, Dr. Jones has discharged you, and you're going to be going home this afternoon, and Dr. Smith will be seeing you in 2 days at 2:30, and I'm just going to review what to do to take care of yourself when you go home." And people go, "Whoa, how about that?" And then so the programming, so we enter the information into the computer and then prints out what we call the after hospital care plan. So they're holding in their hand all the information. The same data goes to Louise on the screen, and then they go through the interaction, basically teaching page by page through the discharge instructions, which are very much tailored to health literacy, so that people can really understand it. There's big fonts and icons and colors, and no legal jargon. Right. It's just really what is it that people need to know when they go home.
Excellent. And for those joining us a little late today, my guest today is Dr. Brian Jack from Boston Medical Center. So Tell us about, you've had a couple of innovations even since Louise. I believe her new name is, there's another one named Gabby. Is that correct?
Yeah. So because of the success of Louise,
Yeah.
we've developed now a program called Gabby. And that Louise, I would classify, and I really honestly think, Justin, that these programs, these systems are models for the future.
Yes.
That a lot of health education will be done this way in the future. I think there's no question about that. And Louise is, I think, an example of a system that is integrated into the hospital system. So it's in the hospital. It assists nurses in doing the hard job of preparing people for discharge. Okay. But it's a patient-facing system. Mm-hmm. The Gabby system is really also a patient-facing system, but is done at home, somewhat separate from the medical system. So there's lots of discussions now about care in the home and people taking responsibility for their own care. And Gabby is an example of that kind of system. So it was based upon my work. So a question about how do you choose what kind of clinical situations should we design these kinds of systems for? And I would say it's very important that we choose big problems. And for example, like we just discussed, the problem of the hospital readmission is a big problem. Yeah. There's all sorts of problems associated with it. And right now, 1 out of 5 Americans is over 65 is readmitted to the hospital within 30 days. If we could reduce that from 20% to 15%, that would save about $5 billion a year. Just that. And everybody agrees that we should be able to decrease from 20 to 15%, and not to zero. And what's the right number? I don't know, but it's probably around 10% or so. So readmission is a big problem. So the big problem for Gabby is women's health care, and especially disparities in healthcare. So Gabby was designed for African American women to identify what their health risks are and to address those health risks prior to pregnancy in an attempt to lower infant mortality and to decrease the disparities in infant mortality. So we all agree that that's a very, very important problem. And it's something that is, in our risk assessment tool that I developed in another project working with the CDC, the expert panel on the content of prenatal care and preconception care. I wrote a special supplement to the American Journal of OBGYN with my colleagues from the CDC about what the content of preconception care ought to be. So when we think about, where should we apply health IT, it's to big problems that have well-defined best practices that people can do. But for one reason or another, people would like to do it, but the systems are not set up for people to do it. So those are the things that we should apply these systems to, and that the readmission problem is a big problem. Nurses, say that this is really important for us to take care of this problem, but we just don't have time to do it. And preconception care, similarly, because it's 110 different risks, it just doesn't fit neatly into the 20-minute office visit. So that health IT could be very, very helpful for that as well.
So where are you testing these innovations? Are they at Boston University School of Medicine or at Boston Medical Center? Where are they? Where are you doing this work?
Yeah, so Louise was tested in patients who were admitted to the General Medical Service at Boston Medical Center. Okay. And Gabby, what Gabby does is it screens for 105 different health risks, and then reviews. And what people don't want to know, they don't want to know, like, here's the book, read about these 120 risks. They want to hear about what are the 6 things that affect me, and that's what Gabby does. She says, okay, we did the risk survey. Here's the 6 things that affect you. And then she gives information about those things, why it's important to health, et cetera. And then does the stage of change question. So identify whether the woman is pre-contemplative, meaning that they don't really quite want to change their behaviors related to that thing, or are they contemplative, like I'm thinking about doing something. And then it's very sophisticated in the sense that if they're pre-contemplative, then we've written scripts for all the risks. That is motivational interview. In other words, motivating people to change their behaviors to fix this problem. And if they're contemplative, then they do a variety of techniques like shared decision making and a whole variety of other things that we do using the science of health behavior change programmed into these systems. and then there's 6 months of content within Gabby. So you can imagine 100 and something risks and 6 months of content. It's absolutely enormous system, and really the first of its kind out there. And then Gabby works with a woman for 6 months outside of the medical system to do things like lose weight, exercise more, eat more green leafy vegetables, and a whole long list of things in 12 different domains as defined by the CDC.
Awesome.
In our randomized controlled trials, so the other big part of these things is that we need, I think, to test our systems. So we've done randomized controlled trials for Louise, and now we've done 2 randomized controlled trials for Gabby, showing that the Gabby system decreases risks by 25% compared to when we do the risk assessment and send a letter to the doctor saying, and to the woman saying, these are the risks identified, do something about this. So Gabby will reduce risk by 25% compared to a pretty, significant intervention by itself.
Excellent. So what types of data or feedback do you have that Louise shows what people think about, or that show what people think about having Louise teach them about how to care for themselves?
Yeah, so for Louise, there's quite a lot of data, but for example, when we say, how easy is it to use on a 1 to 7 scale, almost everybody says 1.
Mm-hmm.
How satisfied is a 1 to 7 scale, almost everybody says 7, meaning very satisfied. When we say, how trustworthy is Louise on a 1 to 7 scale, almost all say 7, very trustworthy, because she's empathic and she has the time necessary to tell people what to do. And how much do you feel that you and Louise understand each other? Again, it's almost all 7s, and that Louise takes the time to be sure people understand it. And then, most importantly, when we ask, who would you rather get your discharge information from, Louise or a doctor or a nurse, twice as many people say they prefer the conversational agent rather than a doctor or nurse. And Justin, it's always the same. They say, I prefer Louise. She's better than a doctor. She explains more, and doctors are always in a hurry. It's the time element that we're never going to have the time. So let's use health information technology for what it's good for.
I agree. So we're going to move into the lightning round. I got a couple more questions before we close the segment, but where do you see the horizon, or what do you see on the horizon in the next 3 to 5 years with this innovation or innovations like Louise and Gabby?
Yeah, I think there'll be more and more of these technologies in the home. Like Gabby's in the home now, but for example, connecting to the medical system. So we now have a new system that no one has really seen yet. And I would love for people who are interested in this sort of thing to contact us about this. So it's at home Louise. So when people leave the hospital, they can then go home and log on and click to say, I want to meet Louise again and have her tell me what she told me in the hospital. Or better yet, their caregivers, their family caregivers, taking care of an elderly patient who wasn't there at the time of discharge, can log on and hear exactly the same. Not just hear, but interact with the character and have teach back, et cetera, all through the time to be sure that they understand. But then they can sign on to the at-home Louise. And the at-home Louise, the goals of at-home Louise are to ensure adherence to medication and to monitor for adverse events and to get them to the first post-discharge visit. So just very quickly, for example, if someone goes home on a new medicine, say an antibiotic, and then a few days later gets a rash, they can immediately access the system and say, I have a rash. And I'm sorry, Louise is very good at identifying that is related to the new medicine. And they say, do you want me to contact the doctor? And then there'll be some sort of information sent to the doctor. The doctor, under new value-based metrics, will say, gee, I don't have to see this patient. I'll just change the medicine, and blah, blah, blah. And so that's it. So the patient's happy because they can immediately access the system and they get their problem solved. The doctor's happy because they can fix the problem and have one less patient that day. The system's happy because the patient's not waiting 2 weeks and then going to the emergency room and likely to get admitted to the hospital. So we can use these systems in a way that helps everybody.
Yeah, no, I see that. I love it. No, I'm glad. The moment I saw Louise, and I learned more about Gabby after the fact, but I see the use cases, and I see how it's making a demonstrable difference in healthcare. So I think it's awesome. But I'm going to move to my last question, just because of my closing segment. I always like to ask this last question on my guests. What is your favorite place to get or be inspired?
Oh, that's a terrific question. We try to go to Maine every year, to Western Maine to go fishing at Rangeley Lake in the rivers out there. But this year I just came back actually from Montana, from the Bighorn River. So if people like to go fishing, well, I just gave away my favorite spot, so everyone's going to go there now. But it's just a fantastic place to go, and a great place if you like to go fishing. And so that's what
I love fishing. So Montana.
It's a place. I'll tell
What
you
do you
all
fish
about
for?
it.
Yeah. What do you fish for? What kind of fish? Trout? Rainbow?
Well, there are trout, different kinds of trout in the Bighorn River.
Okay.
In Western Maine, there are brook trout, only brook trout, which is also a terrific place to go.
Yeah, I grew up on brook trout in Western Massachusetts, actually in New Salem. We had a brook running along the side of our property, and I grew up on fresh brook trout my first early years. So I love it. So I'm a big fisherman. But Dr. Jack, thank you very much, my friend, and thank you for taking the time out of your schedule to join the show. And thank you to everyone for joining us today. And please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific to hear our latest shows. As always, you can track me on Twitter at HIT Advisor and use the hashtag ThisJustinRadio so we can respond to your comments from the show. If you missed any of this episode or want to hear more, all my shows are posted at Apple iTunes, SoundCloud, iHeartRadio, Spreaker, Google Play, and TuneIn. Also, check out the new website we launched at justinbarnes.com. Thanks, everyone. Have a terrific week.